Welcome. My name is Lauren Stiles. I'm the president of Dysautonomia International, and this evening I'm pleased to be joined by Dr. David Systrom, who's an assistant professor of medicine at Harvard Medical School out of Mass General Hospital, and he's going to give us an interesting presentation on exercise research in POTS. He's been doing invasive cardiopulmonary exercise testing in individuals with POTS and other disorders associated with exercise intolerance. And he's going to discuss this research and the types of exercise that we can do that we can incorporate into our POTS treatment plans. And I would say that that exercise stuff generally applies to most types of dysautonomia, how you approach exercise when you have an autonomic problem. The webinar will last about an hour. Dr. Systrom is going to present slides for about 30 minutes, and then we'll take questions from the audience after his slides. But you can ask a question at any time on the control panel that is probably on the left side of your screen. You can type it into the question box, and at the end we will take as many questions as we can, but keep in mind that we usually get hundreds of questions and we can't get to all of them. So everyone who registered for the webinar will receive an emailed copy of it in a few days. If you have friends who wanted to attend but they didn't get to register beforehand, before registration closed, they can sign up for our email list to receive a copy of the webinar in our February e-newsletter. And without further ado, I'm going to pass it over to Dr. Systrom.
Well, thanks very much for the introduction, Lauren. And this is real interesting exercise for me. I had the pleasure of joining the Dysautonomia International meeting last spring and had a wonderful time there meeting patients and other researchers in the area. A lot of good ideas came out of that, and I guess this could be viewed as an extension of all of that. So it's my pleasure to be able to speak to you. It's a little odd for me because I can't see you all, and it's the first time that I've experienced that one. One minor correction: we're one big happy family in Boston. I was at Mass General for many, many years. And about 6 years ago, went over to the Brigham and Women's Hospital the other meeting.
I'm sorry.
No, it's okay. And that is that little blue logo upper right. Having said that, we truly are one happy family. In fact, one of the major research papers I'm going to present to you was done in part at MGH and in part at the Brigham, and collaborators from both places are there. So no harm, no foul. I just want to make sure you knew where to find me. Currently anyway. So the other thing, maybe in the way of a disclaimer here up front, is that I'm not going to present a lot about the exercise prescription. That is something in POTS and related disorders. That is, it's an incredibly important subject. It's one we are tuned into. It's one we're developing, but I don't have enough of our own original research on the type of exercise prescription and how to monitor it and how to follow it up, and kind of the yin-yang between ME, CFS, and the words of wisdom coming down that maybe we should be aware of overdoing, and then POTS, where it's quite clear that exercise itself is as good perhaps as some of the drugs that we have. But I'm happy to field questions on that, and but just won't be much of an official part of my presentation here. So to start, what I need to do for those of you who aren't aware of how we diagnose exertional intolerance at the Brigham and at Harvard, I need to introduce you to the invasive cardiopulmonary exercise test. And shown on the title slide here is a patient who gave his permission to be photographed, and I'll show you a bit of a video. And I'll show you the numbers that we get out of it. And we've found this technique phenomenally useful. It is a version of CPET, or cardiopulmonary exercise testing, but it additionally involves two catheters that are placed in our cath lab around the corner from the exercise lab. First, a pulmonary artery catheter, which is that yellow thing you see in the patient's neck, and a radial artery catheter from which our exercise physiologist is drawing in a radial artery blood sample of arterial blood gas and in the center of the photo. I'll get into the weeds on all of that in just a minute. So I'm going to introduce you to the invasive cardiopulmonary exercise test and tell you how we use it, diagnose and ultimately treat a variety of disorders that result in exertional intolerance. One more perhaps preface would be the patients that we see, and when I present you some of our data, you have to consider how patients come to us, because that does give it a flavor to the type of patient we see, the predominance of POTS and related disorders. I direct at the Brigham what's called a dyspnea center. So for the layperson, that's shortness of breath. It's increasingly a terrible term, and we're probably going to have to change the name of the place, because we really evaluate all forms of exercise intolerance. And that includes any elements of fatigue, shortness of breath, and lightheadedness, especially those three, either alone or in combination. And we see all sorts of patients, about 1,000 new patients a year. My colleagues and I evaluate. Roughly half of them end up with the invasive cardiopulmonary exercise test that I'm going to show you. The other half we're able to figure out the reason for exertional intolerance without doing that test. But I will be focusing on the invasive CPAP and the type of patient who comes to us with some combination of fatigue, shortness of breath, and lightheadedness, either with exertion or positional. So here is a little movie that shows you the test in action. We've got a small village that administers the test, again, around the corner from our cath lab. This individual had the catheters placed. He rolled around the corner in a wheelchair. We popped him up on the exercise cycle, lined him up, and zeroed our various pressure transducers at the level of the right atrium. And then we asked him to do incremental cycling to exhaustion. So the basic part of the test, you can see, is identical to a non-invasive cardiopulmonary exercise test. It is a medgraphic system, metabolic cart that measures pulmonary gas exchange and minute ventilation. That's in his mouth. Then in his right neck is the pulmonary artery catheter, and in his left wrist is the radial artery catheter, from which we're drawing bloods simultaneously every minute for arterial and venous, mixed venous blood gases and lactates. And from this, we get a ton of information, which I'll show you on the next slide. So the non-invasive portion of this, the major thing that we get is an assessment of impairment, and I'll show you what kind of algorithm we have to diagnose various forms of exertional intolerance. And really the cardinal number is the VO2 max, the maximum oxygen uptake at the end of incremental cycling, assuming that the patient did a maximum effort for us, which we can tell from things like the heart rate as a percent of predicted. The special things we get from the invasive cardiopulmonary exercise test are largely from the catheters. So there are pressures. These pressures are not critical for the what we're talking about today, but they are for some other diseases. We can diagnose exercise pulmonary hypertension from the mean pulmonary artery pressure and its change during exercise. We can diagnose heart failure, preserved ejection fraction, in particular, a form of heart failure, by the pulmonary capillary wedge pressure, which we measure every minute during exercise. But what is critical for POTS and other forms of dysautonomia in our hands are these things. The right atrial pressure is the filling pressure of the right heart. It's measured continuously from the right atrial pressure port. And we have ways of correcting for respiratory variation. And as I'll show you in a minute, the cardinal feature of POTS and related disorders is very low filling pressures. Whoops, sorry. The other critical things that we get in chronic fatigue syndrome and in POTS and fibromyalgia and related disorders is the difference between arterial and mixed venous oxygen content, especially at maximum exercise. And as you'll see as we go on here, that's a very nice index of how happy the mitochondria are on the muscle. So many patients with dysautonomia have muscle complaints. That may be fatigue, that may be myalgias, and certainly the post-exertional malaise and fatigue. In the differential diagnosis is a mitochondrial myopathy, whose hallmark during this type of testing is inability to depress this mixed venous oxygen content during exercise or widen the AVO2 content difference for oxygen. So this is an index of how well the oxygen is delivered to the mitochondria in the muscle and how well the muscle takes it up. And I'll come back to all this stuff. So here's our algorithm, and I'm going to walk through this repeatedly, so don't be overwhelmed here. This is a relatively simplified algorithm, and what I want to show you first is the non-invasive assessment of impairment of a patient with exertional intolerance of all stripes. And really, the key number there is the VO2 max or VO2 peak, the maximum oxygen uptake, and as a crude measure, anything less than 80% at peak exercise is deemed abnormal, and there are normative values, big published studies for normal individuals based on age, gender, and an assessment of lean muscle mass derived from the height. So the first thing we ask when we look at these things is, what is the VO2 max? And it looks something like this. We know a patient is impaired if that VO2 max shown over here is decreased. So this is incremental work during an incremental cycling protocol in our hands. Here's the VO2 that goes up relatively linearly, and virtually every disease known to man, including and womankind, Lauren, heart, lungs, circulatory, muscle, all the above will result in some depression of that VO2 max. Now, for the physiologists in the audience, our friend here is the Fick principle, and what one can see is that any depression of that VO2 max, one can begin to tease apart the reasons for by evaluating the components of the Fick principle. So this is cardiac output, so imagine this at peak exercise. If the cardiac output is limiting the patient, that cardiac output will be decreased and there'll be a commensurate decrease in VO2 max. Conversely, if there's a problem with systemic oxygen extraction, and I'll show you that in a little bit, this will be the problem in the parentheses, the inability to depress the mixed venous O2 content. So let's remember for a minute, our first step in evaluating these tests is to assess the degree of impairment from the VO2 max. So in our algorithm, the next thing that I would look for in a patient with suspected dysautonomia is whether the pump, the central pump, the cardiac output is limiting that patient. And this is what it can look like. Central cardiac limit, here's a trained individual with a phenomenally high cardiac output at peak exercise. Here's a patient with some problem with the pump. And I'm being purposely vague there. This can be, in some hands, pulmonary hypertension, can be heart failure, and as you'll see, it can be dysautonomia, and we're going to focus a lot on that. So the peak exercise cardiac output is down, and that drives through the Fick principle a depressed VO2 max here. So when we see, for instance, the VO2 max of 50% and a cardiac output, which we can also express as a percent of predicted of 50%, we can infer that the limit to the patient's exertional tolerance is the inability of the pump to move blood forward, a depressed peak cardiac output. All right, now I just mentioned we see patients with these things with intrinsic disorders of the heart, but what I'm going to focus on here is something that we call preload failure, but please accept for the moment there is huge overlap of what we're calling preload failure during this type of exertional exercise test and POTS and related disorders, orthostatic hypotension and friends. So this is what it looks like. A patient will come to us, their VO2 max will be low, their peak exercise cardiac output will be low. We will rule out heart failure, we will rule out pulmonary hypertension by looking at pressures, and then what we may be left with is low filling pressures as the sole cause for the depressed cardiac output and the depressed VO2 max and presumably symptoms. I'm going to come back to this one. I've labeled this mitochondrial myopathy, but what I've learned over the last few years evaluating more and more patients with dysautonomia is that this can be an actor too, and it may not all be intrinsic mitochondrial problem. It may be vascular dysregulation. I'll come back to that. So let me show you a real live patient here. This was actually a case that I ended up presenting to the cardiologists in one of their conferences at the Brigham, because this patient had been evaluated by them, and like many of you out there, and like many of our patients that we see with dysautonomia, this patient had had about $1 million spent on her, and an unsuccessful attempt at making a specific diagnosis. So her backstory was this. She was, when we saw her, about 30 years old, and she had formerly been a competitive bicyclist, and I mean really competitive and great. And please know that her VO2 max likely back in the day was probably something like 150% of predicted. And she got the flu, or what seemed to be the flu, a viral syndrome, about 2 years before she first saw us. And that was followed by intractable fatigue that never went away, some waxing and waning, but never fully went away, probably progressed a little bit symptomatically. And then associated lightheadedness, which was a little later in that 2-year story. She happened to be an anesthesiology fellow at one of the Boston hospitals. And things got so bad for her that she couldn't complete rounds because of fatigue and lightheadedness. She was often having to sit. And then, as I said, she had a lot of money spent on her with traditional cardiac testing, which I'm sure many of the audience have had done to themselves, including cardiac stress tests. Now, there really weren't any cardiac coronary risk factors here, multiple transthoracic cardiac echoes, pulmonary workup, including full PFTs, chest imaging, and rheumatologic workup, infectious disease workup, all for naught. So no answers, and she was distraught. And this case really got our attention, not only because she was a physician and a former athlete, but because, unfortunately, her program director accused her of malingering and dismissed her from her program. So she came to us totally distraught with no diagnosis. She underwent a non-invasive cardiopulmonary exercise test first in the way of a screening test, and it showed that her VO2 max was only 50% of predicted. And that begat what I'm showing you here, the invasive variety, and these are the pressure measurements. And the important point here is that her right atrial pressure, shown down here, I guess this is magenta, Lauren, never augment. Normally in the upright position, sitting on a cycle ergometer, most of us have a right atrial pressure of about 3 at rest, and then that goes up to approximately 10 at peak exercise. There was no hint of that. In fact, there were a couple of negative numbers. This is what we've come to call preload failure. What I'm not showing you is that her peak cardiac output was about 50% of predicted, as was her VO2 max. So by our algorithm, she had preload failure, no pulmonary hypertension, that's shown here, no heart failure, that's shown here. So decreased cardiac output with no other reason except for low filling pressures. So this case and others like it begat a study. I mentioned it briefly beforehand. This was a combined study with MGH and the Brigham. And this is how we approached this. We had, at that time, about 600 patients who had completed invasive CPETs for a variety of different forms of exertional intolerance. And we had a bunch of diagnoses here, and you can see the percent predicteds here. We don't have to get too deeply into this, but basically we ruled out a bunch of things, including lung limit to exercise, right or left heart limit to exercise, including this, exercise-induced pulmonary hypertension, and we excluded for the purposes of this study a peripheral limit to exercise, which was manifested only by impairment of systemic O2 extraction. So we asked the question, in these patients in whom heart and lung disease was ruled out and who did not have a full-blown mitochondrial pattern with impaired systemic O2 extraction, what limited them? And here they are. We had almost 50 patients who were impaired with a VO2 max that was decreased to less than 80%, but no other good reason for it. And then we had a handful, almost 30 patients who were symptomatic normals. They complained of exertional symptoms, but in the end, we couldn't find anything wrong with them. So we compared these two groups and asked, what's responsible for this group of patients, and this was published about a year ago, a little more than a year ago. So here's what differentiated them. Interestingly, nothing at rest differentiated them. It was only at peak exercise that we found differences. And what differentiated the impaired patients with a depressed VO2 max, but nothing else, meaning no heart lung disease, from normal were filling pressures, biventricular filling pressures. So this is the right atrial pressure, and you can see no difference at rest upright on the cycloergometer. And here it is at peak exercise where there is a significant difference. The impaired folks have a low right atrial pressure, and that is a major theme for all these clinical diagnoses that we evaluate, including ME, CFS, POTS, orthostatic hypotension, fibromyalgia, and friends. Very similar story on the left side. This is the pulmonary capillary wedge pressure. This is the estimate of left atrial pressure from a Swan-Ganz catheter. No differences at rest, but yes, at peak exercise, low filling pressures. So how does this work? How does it make a difference was our next question. So we did a regression of these filling pressures, peak exercise, right atrial pressures in the two left panels here, and pulmonary capillary wedge pressures at peak exercise in the two right-hand panels. And we asked, was there a relationship between filling pressures and VO2 max? And lo and behold, there was. It's not the tightest relationship you'll ever see, but there was a relationship for both ventricles filling pressures. And then ditto, we asked the same question for peak exercise cardiac output here. And lo and behold, in this patient population, referral patterns as I described, the lower filling pressures were associated with lower peak exercise cardiac outputs, and by the Fick principle, lower VO2 maxes, and presumably their symptoms. So filling pressures, low filling pressures in particular, seem to be the key here. We took this one step further over at the Brigham, and we did an interventional cohort of 26 patients or so. And when we identified the low filling pressure pattern and the initial clinically indicated invasive cardiopulmonary exercise test, we then tanked them up with normal saline boluses. And we did so in 500 ml aliquots until we saw a respectable right atrial pressure at rest. We targeted 5 millimeters of mercury. And then we asked them, this will seem cruel and unusual, but it wasn't, to pedal away again. And that was generally about a half hour after the first test. So what you're seeing is the baseline test over on the left of each of these panels, and then after IV normal saline boluses on the right. So it's basically a fluid intervention. I should say right now that none of these patients was held NPO. They had a light breakfast the day of the test. None of them was on a diuretic, Lasix. None of them was away from their usual baseline, meaning we don't exercise people who are in the midst of a viral syndrome or with GI symptoms, nausea, vomiting, and diarrhea. So there were no clinical reasons for dehydration in any of these patients. So lo and behold, we gave normal saline, and you can see the statistically significant and individual responses of VO2 max shown here, the peak exercise cardiac output. I'll tell you what's buried here is that with this intervention, a normal saline bolus, there's a little dilutional anemia, which compromises a little bit the VO2 max rise relative to the cardiac output rise. But the pulmonary hemodynamics, the peak exercise cardiac output, is significantly better. The stroke volume at peak exercise is significantly better, and this is all the net result of improved filling pressures. There was one outlier here for the wedge, and he may have had a little bit of heart failure, preserved ejection fraction. We're not sure what was up with that. So what we took away from this study was that when we take patients with our referral patterns, exertional intolerance, and rule out everything else under the sun, intrinsic disorders of heart and lung, and suspected mitochondrial disease alone, what we're left with is a subset of patients whose exercise compromise can be solely explained, seemingly, by low filling pressures, and can be reversed acutely by tanking the patients up. We don't think this is dehydration, and this is not conditioning, and this was Lauren's suggested sexy title for this webinar. It's not all deconditioning. We did not improve the conditioning of these patients over 30 minutes when we gave them normal saline boluses. So we think we're getting at the root cause of exertional intolerance for many of these patients, low filling pressures, and I'll develop that a little bit more, not all deconditioning and not dehydration clinically. I'm going to shift gears a little bit and show you the results of an abstract at American Thoracic Society we presented a year ago. We just had a similar abstract accepted for American Thoracic Society for this year, and using a slightly different way of measuring things. But I'm going to walk you through this a little bit because I think this is yet another piece of work that suggests that A, this is not dehydration, and B, this is not solely deconditioning. When we see patients with preload failure, again, with lots of overlap with classic POTS on a tilt table test. So I have to introduce you briefly to another way we have of assessing patients' exertional intolerance. This is something called a SHAPE metabolic cart. It's a very simple exercise test that we administer in the clinic at the point of care. It's a sub-maximum constant workload protocol where they step up and down on a sort of a 6 or an 8-inch step over and over again for 3 minutes with a mouthpiece in place. And the pulmonary gas exchange and ventilation measurements are virtually identical to that of the MedGraphics cart during incremental cycling. I won't get into all the details of what we get returned in terms of physiologic variables, but what I'd like to emphasize tonight is something called a multivariate index, and that's this MVI shown up here. And MVI, when it is quite low, is actually a healthier patient. It's a little bit of an odd direction for a variable, a physiologic variable during exercise to go. But what you have to envision is less than 1, patients are healthy, they're not as severely compromised. This multivariate index greater than 1 is the more severely affected patients. And the things that go into this index are estimates of VO2 max, something called an O2 uptake efficiency slope, measurements of ventilation, especially ventilatory inefficiency for the physiologist, that's the VE-VCO2 slope during this test, and related disorders or related physiologic parameters. So here are our patients with that SHAPE test done in a contemporary fashion with the invasive CPET who are relatively healthy by the non-invasive test. Here are the patients who are sick, more sick. And lo and behold, some interesting things pan out here, and here are the significant values here. Our patients with the SHAPE test that suggests they're healthier, in fact, have a higher VO2 max as a percent of predicted, almost 80% compared to 2/3 of normal for these patients who have the worst index on the non-invasive test. And the mechanism by which that VO2 max is better in this healthier group of patients is shown over here. It's the peak exercise cardiac output. At peak exercise, we couldn't identify differences. Remember, these are all patients with preload failure, so they all have low filling pressures, but we couldn't identify differences between the relatively healthy ones and the ones who weren't by ventricular filling pressures, and I'll ignore these guys down here for a minute. So all patients with preload failure identified by CPET, healthier group over here on the left, less severely affected over here on the right, and the mechanism by which they're sicker over here is peak exercise cardiac output, again associated with low filling pressures by definition. So what we did was borrowed something from Blair Grubb, whom many of you know at Toledo, Ohio, and that's pyridostigmine or mestinon. He uses this as one of his bullets in his gun for POTS. We had a particularly difficult patient with POTS, got onto this, had phenomenal success, and then this grew. So all of these patients I'm presenting to you in this abstract form had preload failure. All of them were treated for months at a time with pyridostigmine. We can talk about maybe in the question and answers about what doses we use. And we asked the question, do they get better physiologically? We don't want to go repeating the invasive test. We repeat that shape test. So we're going to repeat this non-invasive test and look at what happens to the multivariate index here. So here we are with the baseline MVIs, and what you can see is that we have about a third of our patients with preload failure have a severe multivariate index on the non-invasive test, meaning greater than 1 at baseline. Here they are at follow-up, and the mean follow-up was measured in months, roughly 6 months. And you can see that the vast majority of these severely affected patients improved by this objective measure of largely aerobic capacity, but some hyperventilation-related variables involved as well. And then the actual number, the MVI shown here, it moves in the severely affected group who began with an MVI of greater than 1 down into the phenomenally normal range, at least as a mean, with a couple of outliers here. So we have objective evidence that when we treat patients with preload failure, and again, I'll emphasize, majority of these patients have POTS, orthostatic hypotension, a large overlap of the Venn diagram. We're treating them with something that does nothing to, that we think by itself to conditioning. We can't conceive of any way that this is changing the volume of plasma, for instance. What we think is likely happening is that this is cholinergic stimulation of the sympathetic outflow that promotes venoconstriction and improves cardiac output in these patients. So to put another way, we believe that a substantial percentage of patients with preload failure have dysautonomia. It may be a ganglionopathy, which would be up high. It may be a small fiber polyneuropathy, the symmetric distal variety. And I'll get into that in just a second. But pyridostigmine makes it better. We think mestinon, by enhancing the concentrations of acetylcholine at the synapse between nerves, or perhaps between nerve and smooth muscle in the vasculature, helps the patient augment preload, augments venoconstriction, primes the pump, as it were, improves cardiac output, and improves VO2 max, and the majority of these patients feel better. So mestinon has evolved as not our exclusive drug, but one of our go-to drugs in the treatment of this disorder. The last thing I wanted to leave you with is the notion of something that we're really developing. So I don't have a lot of data in POTS yet, other than to say the majority of patients who have a depressed VO2 max, a depressed cardiac output, no left or right heart disease, and yes, have preload failure, additionally have a problem with the ability to extract oxygen. Now, that problem physiologically is the hallmark of a mitochondrial myopathy. But what I've come to learn with recent discussions with colleagues in dysautonomia, and especially small fiber polyneuropathy, is that vascular regulation of the cardiac output flow has to be normal in the muscle for the muscle to extract oxygen normally. So put another way, the arteriolar resistors in the muscle are the traffic cops for the cardiac output. During incremental exercise, they should be diverting blood flow and therefore the oxygen to where the mitochondria are in the slow twitch muscle fibers. If they're unable to do that because of an autonomic neuropathy, we will have a pattern that looks like a mitochondrial myopathy. So the next couple slides I'm going to show you are not from POTS patients. They're from another disease that we study a lot at the Brigham, and that's pulmonary arterial hypertension. I'm going to show you this because we now know that pulmonary hypertension is associated with mitochondrial dysfunction. We initially thought this was bona fide mitochondrial disease, but we're coming to recognize that some of it is vascular dysregulation at the arteriolar side. And this might not be too dissimilar from POTS patients. So I want to just show you a couple of quick slides on what we've done in pulmonary hypertension, but also suggest to you that we need to do this in POTS-related disorder. So we've looked at systemic O2 extraction in pulmonary arterial hypertension and compared to LV diastolic dysfunction and systolic dysfunction, and there is a disproportionate problem. This means something's wrong in the periphery. Either something's wrong with the mitochondrial integrity itself or the vascular distribution of cardiac output. We have further looked at pulmonary hypertension using an index of mitochondrial happiness, which is phosphorus MR spectroscopy. And just for fun, I want to show you a normal or a PH patient lying in our magnet doing incremental exercise or constant load exercise, and we're simultaneously with the metabolic cart interrogating the muscle and specifically looking at the muscle's ability, the mitochondrial ability to resynthesize phosphocreatine after a brief exercise bout. This has evolved as one of the very nice non-invasive indices of mitochondrial happiness, as it were, in the muscle. And remember that mitochondrial happiness could be by virtue of vascular tone and regulation in the microcirculation or mitochondrial dysfunction itself. This is a picture of the PAH patient. The image shows some atrophy of the thigh muscles, the vastus medialis in this case. And here's what things look like when we interrogate a normal with phosphocreatine declining, and then in recovery it goes back up. PH patient declines quickly, and then as I'll show you is very slow to recover. This is phosphocreatine going back up after exercise in a normal individual very quickly with a half-life or a tau of 30 seconds. Here's the patient with pulmonary hypertension. This correlates very nicely with muscle biopsies, fresh muscle biopsies, and interrogation of respiratory chain with things like the seahorse assay. So I hold this out because I would like to tell you that in addition to what we think is deficient priming of the pump, meaning inadequate venoconstriction in POTS and related disorders, there is also a problem with systemic oxygen extraction. And we would like to drill down on this further in the near future in POTS patients and dysautonomia patients and determine whether that's an intrinsic mitochondrial problem that coexists with a vascular problem, or whether it's all vascular dysregulation giving the very same pattern. So that's essentially what I wanted to tell you. Here's a picture of the Brigham. Lauren, this is where I am now. This is where to find me, right up here. This is our group. Aaron Waxman is the director of our pulmonary vascular program. Barb Carkle is one of our clinician teachers. Rudolph Oliveira came from Sao Paulo, where he is now, has returned, and he's done a lot of the work. He did the pyridostigmine work, two of our exercise physiologists and one of our PA. So I'm going to stop there, see if there are questions, and happy to entertain any. Thank you for listening.
Oh, there are lots of questions. You can maybe put your last slide up or another one so we have something to look at.
Let me go back, right? There we go.
Okay, so just for starters, somebody said, I think it's a good question. Can you explain what filling pressure is in layman's terms?
Yeah, great question. So here's what I tell the patients when I did that as recently as today, this afternoon at about 1 o'clock. We tell them they have wimpy veins. That's a good way to remember it. But view the heart, right and left heart, as a pump. And if you are going to have that pump function normally and put whatever it is you're trying to pump forward, you have to prime that pump. So preload failure, we think, is the abnormal filling during diastole, meaning in between beats of the heart, of both right and therefore left heart. You have to get to the right first and then pump through the lungs to the left. So if the right heart filling is deficient, almost by definition, the left heart filling is going to be deficient. And then the flow going out the other side, our systemic cardiac output, is deficient. So it's really basically failure to prime the pump. That is preload failure.
Okay, thanks. Someone else has asked, what is the difference between invasive cardiopulmonary exercise testing that you're doing and a stress echo?
Right. So there's a number of differences. They're complementary techniques, and I'm not going to for a second malign the stress echo. The stress echo is almost always, in fact, has to be a transthoracic look at left and right heart with exertion. But the problem with the echo window is that the patient really has to be either supine or at least partially recumbent to get a good look at the heart. It is phenomenally difficult to do cardiac echo in the upright position. We do it on occasion for very specific indications, but not for this one, not for POTS-related disorders. Technically, it is a bear to do with exercise. There's respiratory movement, the heart is moving around, and then moreover, if you're doing that exercise in the upright position, it's phenomenally difficult to get a high quality echo window, meaning bouncing the sound waves off of the heart. The real critical part, so what's evolved in cardiac stress testing, and in particular the stress echo, is a treadmill exercise protocol. And then what they do is they throw the patient down in the lateral decubitus position and slap the microphone on and try to get some answers in recovery. So there are a couple of problems with that, and we published some on this. One is that many of the abnormalities that we document at peak exercise during and at peak exercise go away very quickly in recovery. So if you're not super quick, you can miss a lot. The other thing is, with respect to dysautonomia or POTS and related disorders, as soon as you lie that patient down, you're actually removing the very pathophysiology that is making them feel poorly. Same for resting right heart catheterizations, which are all done in the supine horizontal position. You don't see the pathophysiology unless the patient is upright. And you don't see it unless it's during exercise, not after exercise. So for those reasons, stress echo is a tough one for this disease. There are other places for it. Diagnosis of coronary disease, it can help sometimes. And when that pulmonary capillary wedge pressure goes high, not low, it can help determine whether dynamic mitral regurgitation is at play. But those are very different types of patients. So for these disorders that we're talking about today, really you need to be supine, and you need to catch things during, you need to be upright, and you need to catch it during exercise.
Is this testing just for the invasive cardiopulmonary exercise testing? Is this just for research right now, or would your office recommend that the average POTS patient gets this done, at their local hospital?
Yeah. So here's our thinking on that. No, everything I presented to you, with the exception of that interventional cohort with the normal saline boluses where we added a second test, all the initial tests have been clinically indicated. And what we're really looking for is predominant patterns that suggest dysautonomia on the one hand, or mitochondrial dysfunction in the muscle on the other, because there's a lot of overlap between the two. And the treatments right now are quite different for the two. If we see predominantly a problem with O2 extraction and the filling pressures are normal, the mito cocktail is in play, and referrals to the mitochondrial mavens is what we would do. And there are evolving treatments for mitochondrial dysfunction when we think it's intrinsic. Conversely, when we see predominantly dysautonomia, it's a very different treatment algorithm. So we take the time to get some science behind exactly what ails any individual patient. Having said that, Lauren, if I were to see a patient who had a tilt table that was diagnostic of POTS, and they were on a beta blocker, or perhaps on Florinef, and they were doing phenomenally well, they don't need this test. It's fine. It's really, I think, more the problem patient that we think this is indicated in. And often, most often, when we see POTS patients, they have had empiric treatment tried, or they've had treatment as a result of that tilt table test, and they haven't responded either at all or fully, and they're frustrated and they want to make certain there's nothing else and we can provide that. So that would be my answer. More severe or less than optimal treatment responses.
Okay. Someone is asking a more sort of generic question. This person is an athlete and they want to do a sprint triathlon this year. They have POTS. They don't want to not be able to compete. So they're wondering if there are specific things you might recommend to get their heart rate down during exercise.
Oh boy.
That's basically, how do you treat POTS?
Well, right. Good question. You know, so palpitations, fast regular palpitations that are positional or with exertion can be, as I bet most of this audience knows, a real problem for the patient. The way we think about it is slightly different in that, A, we want to make certain there's no arrhythmia. So many patients have had event monitors, Holter monitors, and friends to rule out a primary arrhythmia, and there isn't any. And the tachycardia in POTS generally is adaptive. It's a nuisance to the patient, but it's adaptive in the way that stroke volume is the primary problem. So the failure to prime the pump results in depressed stroke volume. I showed you that quickly in one of the paper's slides. The tachycardia is a normal cardiac compensation for inadequate stroke volume. So now, having said that, there is a literature, and I'm aware of it, that there are certain patients with sympathetic overdrive in POTS who, like heart failure, have, as a result of that, a downregulation of their beta adrenergic receptors, and they have tachycardia, and the beta blocker, because that will slow their heart rate and block this adrenergic excess over time, restores some of the sympathetic responsiveness of the patient. So I guess I can't jump right on accepting heart rate slower is going to be better during exercise, during upright exercise. It might not necessarily be so. You know, not as true perhaps in the resting state or with orthostatic changes. I accept that. There is an interesting thing I'll just touch on briefly that is really the great interface between the athletic heart and pathologic dysautonomia, or what we would call preload failure. And it's really, really interesting, and we haven't, I don't claim to have sorted it all out yet. Ben Levine down at UT Southwestern is one of the world's experts on this. He's written about the Grinch heart and related disorders. He's also written about athletes, mostly using non-invasive exercise testing and non-invasive measurements of cardiac output, which is something that we do as well. I will tell you anecdotally, and because we haven't published all of this yet, except it is in the most recent ATS abstract that'll be presented in San Diego in May, that there is a subset of well-compensated dysautonomia that we see. So these are patients who come to us often with some exertional or positional lightheadedness, sometimes with a bona fide tilt table POTS diagnosis. And when we exercise them, their VO2 max is 90% of predicted, 100, even 110% of predicted. But often when they get to us, what they tell us is that their training and their exercise capacity in the field has declined. So they will tell us that they used to be able to do, you know, the 6-minute mile, and now they're at 8-minute miles, and or other objective indices. And when we test them with invasive CPET, we'll see phenomenally low filling pressures. But interestingly, the cardiac output is reasonably well preserved. They're a subset of well-compensated dysautonomia. Sometimes they have more of an extraction problem than what appears to be inadequate venoconstriction, but they have a low filling pressures. Now, Dr. Levine and his colleagues, and I hope I'm not misquoting, had have MRI studies that suggest that in the athletic heart, one can get 4-chamber, very compliant enlargement of both atria and both ventricles. And that those athletes, those aerobic athletes, can be predisposed to orthostatic intolerance. So they can actually end up in some settings with POTS or even orthostatic hypotension in extreme. Yet they seem to have acquired it by virtue of aerobic training and volume training of their atria and their ventricles. So whether you call that a disease or not, or whether it's kind of a maladaptive exercise response, might be semantics. But here's the part that's in our abstract. When we treat those patients, even when they're 110% of predicted VO2 max and cardiac output max with Mestinon, they get better. They feel better, and they have objective indices of being better. And we've been using a cardiopulmonary exercise test, a non-invasive one with a cardiac output component, similar to what Dr. Levine's done, called the Innocor device, INNOCOR. And it shows that cardiac output is better and systemic O2 extraction is better, even though they begin in a VO2 max range that all of us would hope to die for. So there's this very interesting subset of aerobic athletes who may have POTS, bona fide POTS or POTS-like features, whom one can treat and seemingly make better.
So the next question is actually a question I had for you too, so I'm glad someone asked it. We know that a good majority of POTS patients have hypovolemia. Is the preload failure that you're detecting, can you distinguish hypovolemia related preload failure from a failure of the sympathetic vasoconstriction preload failure? I mean, I know you did it with saline, but would a POTS patient who's fully volume loaded with saline have the same amount of preload? I guess I'm not asking the question properly. But my point being, can you distinguish what's just hypovolemia and what is a sympathetic vasoconstriction problem?
Yeah, if it's hypovolemia, it's the subtle variety. And as I said, with respect to our the paper that I mentioned, the saline paper, none of these patients clinically was dry. Now, if you did real sophisticated measures of plasma volume, yes, likely some of them would appear to have low circulating blood or plasma volume. So maybe some of them got better with saline. But I think in answer to that one and the deconditioning thing, pyridostigmine, although it's an incredibly useful tool in treatment of these disorders in our hands, but I think it also is a useful tool in addressing the pathophysiology. Because to my knowledge, and I'm always willing to be proven wrong on any of these things, there is no good mechanistic way that Mestinon or pyridostigmine augments plasma volume. But what we see is measures that are reflective of increased cardiac output when we give Mestinon. Now, I guess the naysayer could hypothesize, and I guess I would accept this. Maybe you have a combination of things. Maybe you have both circulating plasma volume down in some patients, and you have inability to venoconstrict, and that's kind of a very difficult combination. And what you're treating, Dr. Systrom, with Mestinon is the venoconstriction part, and they get better. So maybe that is out there, and maybe that needs to be done. But mechanistically, I'm unable to come up with a good reason that Mestinon would augment plasma volume, but an overwhelming majority of our patients get better on it.
Mm-hmm. When you say they get better, their orthostatic tachycardia and orthostatic symptoms get better, or because POTS is, it's defined by the orthostatic presentation, but it's GI symptoms, it's sweating symptoms, temperature sensitivity. So do you see mostly the orthostatic stuff getting better, or do you see the overall symptom profile?
Both, actually. Now, I can't claim to have done formal before and after tilt table tests, but others have in small series. Like Vanderbilt, I know, did this a while back with pyridostigmine and showed that the tachycardia, orthostatic tachycardia, improves with Mestinon. Anecdotally, and we are putting this together in a more formal way, meaning a review of systems and questionnaires, all of the things that you mentioned tend to get better on Mestinon. So in fact, I've had extremes where patients have told me, oh, my exertional tolerance is a bit better, but what's really better is my constipation is gone. And so I've heard that story time and time again, even brain fog. Again, anecdotally, we don't have the numbers yet, but we're putting this together better on Mestinon. So lots of things seem to get better. There's mostly concordance. Mestinon itself, especially initially, can cause some GI symptoms, but usually they go away even with ongoing treatment.
Someone else wants to know, is there a way that they can enroll or participate in your research?
Yeah, let me think about the best way to put that out there. Lauren, you said you're going to float this on your website.
Yes, the video ends up on our Vimeo
page.
Okay. So you put a time limit on it because if it's up there indefinitely, you don't want people contacting you 5 years from now. But
right. Yeah, no, but I think the short answer is sure, and we are moving toward new therapies. Another area that I didn't mention a lot of because we're just beginning to publish it, I'll just mention it briefly now and then get back to the research studies. We're collaborating extensively with Anne-Louise Oaklander over at MGH. She's, for those of you who don't know her, she is an autonomic neuropathy neurologist and very much aware of POTS and related disorders, but she is the guru for small fiber polyneuropathy. In our hands, when we looked at those patients I showed you who were followed up with that SHAPE study with skin biopsy looking for neurite or axon density in the epidermis, her test, FDA approved test for nerve density. About 70% of our patients with preload failure of the more severe variety had a small fiber polyneuropathy. The less severe ill patients that we've been following with Inacor, that number falls a bit, and in our hands is probably closer to 40% small fiber polyneuropathy. She just published a study in one of the neurology journals 2 weeks ago. It was a cohort of about 60 patients who came to her mostly with a neuropathic pain, not exercise intolerance, treated with intravenous immunoglobulin. And so we have had some experience with intravenous immunoglobulin and other forms of immunotherapy, especially for those patients with POTS-like symptoms, preload failure, and the small fiber polyneuropathy. And we're moving forward with a clinical trial for that one. Using Mestinon prospectively, we've proposed to do a double-blind placebo-controlled crossover study to prove once and for all to the world that this is a Mestinon responsive disease. The other area that we're looking to organize is a vagal nerve stimulator. And you may know there's a new variety that is transcutaneous, stimulates the auricular branch behind the ear of the vagus nerve. And there are a lot of interesting, potentially good things, both anti-inflammatory and the vagal stimulation itself, the cholinergic tone, that may be similar to Mestinon, that at least anecdotally help patients with dysautonomia. So those are two studies that are in the offing, and yes, we will be looking for volunteers for those things, and in the very near future. So what I think, Lauren, logistically, maybe we could do is I could get a contact phone number I have to vet this a little bit back at the
Sure.
Fortress, but we could get that on your website along with this webinar, and if interested patients want to contact us, they can.
Yeah, we are always available to help for dysautonomia research recruitment, whether it's POTS or another type of autonomic disorder. We have a whole page on our website about participating in research and different studies we're aware of, and we also have links to clinicaltrials.gov for studies we may not be aware of. And so I actually was very interested. I know it's 8 o'clock and we should probably wrap up, but I just wanted to mention Dr. Oaklander has invited Dysautonomia International to come up. She has a lecture at Radcliffe, which is part of Harvard, in Boston, and she has a lecture on February 5th I think it starts around 5 p.m. There's a link on our Facebook page, on the events section of our Facebook page. You have to register in advance if you want to attend. It's a live event at the university, and she's going to be lecturing on her part of this research, the small fiber polyneuropathy type of research, and she's finding this in fibromyalgia and POTS. It's previously been found in chronic fatigue syndrome. Actually, Dr. Freeman, who's on our medical advisory board, who's at Harvard as well, published years ago that 65% of CFS patients have small fiber polyneuropathy. And there's research from Europe showing that about 65% of Ehlers-Danlos syndrome patients have small fiber polyneuropathy. So sort of, there's a theme here, and we are glad to see that your group is doing more research and trying to understand how that neuropathy relates to POTS or not, and what types of things we might be able to do to treat it. One thing I've always wondered about is, if 70% of a patient population has this small fiber neuropathy, and what does the other 30% have? So I actually emailed Dr. Oaklander about a week ago, and I said, do you think we're just really bad at identifying small fiber neuropathy with the current tools we have? Maybe the other 30% have it too, and we're just not finding it because our tools are pretty rudimentary right now. And I know that Dr. Freeman at Harvard, who's on our board, we actually gave him a grant, I'd say 2 years ago, maybe. It was from funding raised at the Boston POTS Walk by Dysautonomia International volunteers. We gave him a small grant towards developing a new diagnostic test for vasomotor neuropathy. And that's the type of neuropathy that, if it existed in these patients, would cause the failure of the sympathetic nervous system to constrict the blood vessels. If you're missing your vasomotor nerves, or some of them, you're going to have a hard time preloading your heart, right?
Yeah.
So anyways, so there's a lot of cool stuff going on up in Boston. So thank you so much for your time. We really appreciate it. Apologies to everyone else. We didn't get to all the questions. There were so many. But it's a very technical lecture, and I'll probably have to watch it again to sort of absorb all of it. I already heard part of this last year at our conference, which we appreciated. Just wrap up. This will be on our website. You'll all receive an email with it. And check out the events on our Facebook page. Dr. Oaklander's other part of this lecture is February 5th in Boston, and the Boston POTS Walk is May 12th. So thank you so much for your time, Dr. Systrom.
Oh, you're so welcome, Lauren. It was a pleasure, and to be continued.
Yes, thank you. Take care. Good night, everyone.
Good night. Bye.